Lovely, thank you. Okay, so hello again. Welcome to this SPLICE lecture on neurology. So I think this is the third final one that I'm going to be doing for you guys, and it's quite a big topic, as we sort of were discussing a bit just then. So what I've tried to do is kind of condense it into the high yield topics. So I'm hoping to kind of limit this to about an hour and a half. And I'm going to try and keep it succinct, to the point, etc. But yeah, so just before we start, just a big thank you to Dr. Gibbs and Dr. Groves, who've had a little look through the slides just to make sure everything is all right and in fitting with what you guys need to know. So what I'm planning on covering today is basically what I think are the key topics in neurology and the things that you absolutely do need to know. It's a massive topic with loads of weird and wonderful conditions that would take way more than an hour and a half to go through. So, like I said, I've chosen these kind of main topics. I'm going to do quite a lot of detail on strokes because that's I think that's a really fundamental bit of neurology to grasp at this stage. And then a bit on Parkinson's, epilepsy, headaches, which I think are really important topics. I put meningitis in there. I'm not actually going to cover it because it's been done a bit in Ollie's ID stuff. So, but just to make you aware, that's quite an important topic as well to be aware of. Then a few slides on MS, polyneuropathies, motor neuron disease, and then a little bit of cranial nerves at the end. So that's what I'm going to try and cover. These are some topics that I've not covered. I've tried to label them in terms of usefulness. Basically, if you get time, then go through them. But the key bits of neuro that you should need to know will hopefully be covered today. Then these are the learning outcomes from the UCL curriculum map. I've put them here, so if you want to review to kind of work out whether you've accomplished them, then you can. But we're going to do a bit on the systematic classification of neurological diseases, because I think that's actually really helpful in terms of diagnosing and forming differentials. And then the focus will largely be on recognizing presentations and then management plans. So that's the aim of today, and hopefully you'll have a good idea of kind of what's going on in terms of any neuro presentation. So how to approach neuro, and I'm going to kind of share a little bit of basically the system that I used to use. I've put this definition in because I think it's just sort of highlights how diverse neurology is. It can basically affect any part of the body with the nerves, which is essentially everywhere. So because it's that broad, we kind of need to try and narrow down. So firstly, where is the lesion? And this is just a rough idea of how to break things up. So basically, when you think of neuro, you think of the brain, which is kind of quite understandable. The brain itself made up of the two cerebral hemispheres, then your inner basal ganglia, the brainstem, and then the cerebellum at the back. The cerebrum itself contains the frontal lobe. So this is tasked with movement and thought process. Your parietal lobe for sensation, temporal lobe for emotions and memory, and then occipital for vision. And then any lesion sort of at this level can be termed encephalopathy. And this is going to present quite broadly and acutely with altered consciousness, confusional states, seizures, mood changes, or with a slower onset like a dementia. It might even present a bit more localized and focal with some signs in the limbs, weakness and sensory loss. And some of the key causes at this level is strokes and focal epilepsy. Then moving down a little bit, you've got the basal ganglia. And these are your collection of nerves basically tasked with coordinating movement. So any lesion here, such as you can see in Parkinson's disease, will cause these involuntary motor problems, so a tremor, dyskinesia, these kind of random unintentional movements. Then the back of the brain, you've got the cerebellum, which again is kind of linked to the brainstem and involved in balance and coordinating movements. If you get a lesion here, then you might get some of these characteristic Danish symptoms, which I've written out there. And again, there's a whole host of problems that can cause it. So stroke, trauma, alcohol, infections. Then continuing down, brainstem. So this is essential for a lot of your core processes that keep us alive. So your respiratory drive, your circulatory drive. And they're also home to parts of the autonomic nervous system and many of the cranial nerve nuclei. So therefore, lesions here might present with cranial nerve deficits. And I've got a bit of that at the end. Then moving out of the head, you've got the spinal cord. So the spinal cord is still part of the central nervous system. So lesions here are going to give you your upper motor neuron signs. And the spinal cord is sensitive, can be damaged quite easily. One of the most common causes is MS of spinal lesions. Some other conditions to be aware of are cord compression, trauma resulting in pathology, so slip discs, things like that. And then motor neuron disease as well can affect the spine. Then moving out from the spine, you've got your nerve roots, the location at which nerves leave the spinal cord. These are particularly susceptible to damage, as went through a bit in the orthopedics lecture. And as these nerves have now left the spine, these are now lower motor neurons and will present with signs in their radicular territory of that nerve, and commonly seen kind of C5 to C7 distribution in the arm, or sort of L5S1 in the leg with your kind of sciatica type symptoms. And then cauda equina, which we touched on, is a rare but very serious pathology to be aware of there. Moving outwards, again, you've got your peripheral nerves. They run through the limbs. These can be damaged as a single nerve, as is the case in a mononeuropathy. So examples of this is your radial nerve injury causing your wrist drop, or median nerve damage causing carpal tunnel syndrome. Then there's this multifocal neuropathy, which is a phenomenon where you've got lots of different nerves affected in different locations without seemingly being connected. And then you've got polyneuropathies. So these are where multiple individual nerves are affected together, but this time they've got a common cause. So this could be a metabolic or a vascular cause like diabetes, or you can get an infective cause like Guillain-Barré syndrome. And then the most distal parts of the nervous systems are the neuromuscular junction, and then also the muscles themselves. So issues at the neuromuscular junction are conditions like myasthenia or Lambert-Eaton, where you've got problems with your neurotransmitters or the receptors of the neurotransmitters. There's kind of a loss of translation from the nervous system to the musculature. And then just to touch on the muscles itself, myopathies are something to be aware of. The problem isn't with the signal reaching the muscles, it's actually the composition and function of the muscles themselves. So polymyositis is a differential, as we've gone through in rheumatology, as are your muscular dystrophies, so Duchenne's, Becker's. In Duchenne's, the signals reach the muscles fine, but it's the muscle fibers that are degraded and they're filled with fat, fibrous tissue, and so they can't contract, and that causes the problems. Right, so that's where is the lesion. So worked out kind of where it is. Now the second question is what's caused that. And I think the best way to approach that is by assessing the timing and the onset of these symptoms. So the first time frame here is your sudden onset. Symptoms occurring over a matter of seconds, and this is nearly always vascular. So your sudden onset headaches, stroke, subarachnoid hemorrhage, blood supply is interrupted for whatever reason, tissue stops working. Paroxysmal, so I've put this in second. I put this in here mainly for the recurrent aspect of it. So this is things like epilepsy, migraines, these presentations that keep coming back. They can come on suddenly, but they kind of can keep recurring. And it's this underlying problem with the neurological tissue rather than the vasculature. Then acute, subacute kind of go together. These happen over hours, days, weeks. They're not happening instantly, but they develop pretty quickly. So this could be an infection or a drug reaction. Some fast-growing tumours might cause this, or kind of inflammatory problems. So here are things like meningitis, Guillain-Barré syndrome, which aren't causing pathology immediately, but are getting progressively worse over hours and days. And then finally, your chronic conditions, the longer-term ones over weeks, months, years. And these are often neurodegenerative in nature, so things like Alzheimer's, Parkinson's, multiple sclerosis. Just kind of a guide. So when you see a question or a patient, what symptoms are they presenting with, and what does that say about where the lesion is in the nervous system, be it central, peripheral, upper, lower motor, and then think how quickly did these symptoms come on? Were they immediate, like a stroke, or did they come on over months and years, like Alzheimer's? And that should give you a pretty good approach of how to answer your neurology question or with your neurology patient. So having said that, here's the first SPA. Okay. Yeah, very nice. So, majority of you getting this one right. So, it's the first SBA on strokes. So, the collection of symptoms we've got here are sensation and weakness of the right lower limb. And then, in addition to the information that the upper limbs and the face aren't affected, this points quite heavily to anterior cerebral artery. And then, since you've got the weakness and the sensation loss on the right-hand side of the body, lesions are likely to be in the left hemisphere due to the crossover of the fibers in the brainstem and in the spinal cord. If you remember your second year neuroanatomy, then the reason the other answers are incorrect is the middle cerebral artery presents with upper limb signs and facial signs more than the lower limb signs, and then the posterior cerebral artery would give a clinical picture of a homonymous hemianopia. Okay, another SBA, and then we'll go through some strokes. Lovely stuff. Okay, so I actually thought this was going to be a bit of a trickier SBA to kind of highlight some of the niche stroke patterns, but you've all done very well there. So this is lateral medullary syndrome or Wallenberg syndrome, which is caused by an occlusion to the posterior inferior cerebral artery, as most of you have said there. It presents commonly with this sort of ipsilateral face signs and then contralateral limb signs, with a few cerebellar signs as well. A good differential here would have been option B, so the anterior inferior cerebellar artery, as it also presents with the ipsilateral face signs and contralateral limb signs. But crucially with that, you'll get a degree of hearing loss, and then the facial signs are slightly different, but we'll go into that a little bit. I'm going to try and go through the reasoning behind a lot of these presentations in the next few slides, because it certainly helped me with the understanding of kind of what happens. With strokes, like I said, I'm going to go through in a bit of detail on strokes, because I think this is the one aspect of neurology that you can all just completely nail. So what are strokes? I'm sure you all know by now you've got your two strokes, the two types, ischemic and then hemorrhagic strokes. Ischemia, much more common. Thrombosis, embolism, hypoperfusion causes a blockage of blood supply, and then so your brain requires a high oxygen demand, so it can die very quickly in the absence of oxygen, and that will result in your neurological deficit. Hemorrhagic stroke, your vessel ruptures, is leaking blood into what is a closed cavity, and that in itself can cause problems due to pressure buildup. Tiny bit of physiology. The cause can come from the cerebral vessels themselves, as is the case in atherosclerosis or arteriovenous malformation, an AVM. Or it can come from somewhere else in the body, so an embolus can fire off into the brain, which can happen from the heart in your AF sort of situation, atrial fibrillation kind of situation. And then another cause is that you can decrease your perfusion pressure and blood flow so much that you can't meet the oxygen demand of the tissue. So in severe hypovolemia, you can get this decreased perfusion pressure, which can also cause a stroke. And then the best way to understand strokes is if you can understand the vascular pattern. And yet again, another throwback to second year. But hopefully you're quite familiar with this. This is the circle of Willetts, and this is essentially the blood supply to the brain. So you've got your two internal carotids at the top here, and they come into the middle of the circle, largely supplying the anterior circulation. The big vessels here being the anterior and middle cerebral arteries, which supply most of the frontal, parietal, and then the temporal lobes of the brain. Then at the back, you've got these kind of two vertical arteries coming up the spine, and they join together to make your basilar artery. And then the key branches coming off these are the posterior cerebral artery, which supplies your occipital lobe, and then some smaller branches which supply the brainstem, the basal ganglia, and then the cerebellum at the back. It's just quite a nice diagram to highlight kind of roughly where in the brain the vascular territories are. Another point to make here is that the middle cerebral artery is the most commonly blocked one. This is because it's basically the largest vessel coming off the circular Willis, which is the path of least resistance. So has the most amount of blood, and that's the easiest pathway for a clot to take. Right, so the first of your kind of big three strokes is your anterior cerebral artery stroke. And from the previous slide, it largely supplies the medial part of the brain, so kind of the middle bit. And so the top right corner of the slide got this thing called the homunculus. And basically what this is trying to show is the different areas of the cerebral cortex that supply the kind of lower limb motor, that cover the motor function of the limbs and the face. And because it covers this medial part of the brain, you're looking at the lower limb essentially is what's most likely to be affected in an ACA stroke, much more likely than an upper limb or the face will be affected. And then again, because the fibers decussate, they cross over, there'll be signs on the opposite side to the lesion. So your typical history, left leg went suddenly numb and weak. That's kind of your typical history. Then your middle cerebral artery, we touched on, this is the big one, the main one. It's the one that's most commonly affected. The middle cerebral artery covers quite a wide area, and subsequently quite a large area of this homunculus as well. So as a result, you get problems in the arm and the face much more commonly than the leg. You can also get eye involvement if the area of ischemia is large enough. And then because of the location of Broca and Wernicke's areas, you're going to get some speech problems as well. And then the classic history here is someone's arm and their face going numb. They possibly drop their cup of tea, and then they're talking nonsense down the phone to their son or daughter, who's then called an ambulance. That's the sort of thing you might see in an SBA. Then the other major artery in the brain is your posterior cerebral artery, which pretty much exclusively supplies the occipital lobe. So it causes damage to nerves somewhere further back than the optic chiasm, and thus kind of result in this classic homonymous hemianopia. So homonymous, same side, hemianopia, loss of half your vision. So there's a loss of vision on the same side of each eye. And this side will be contralateral. It'll be the contralateral side, and this is due to the way that kind of the light hits the retina that flips the image. It's all a bit confusing, but if you just remember the contralateral aspects of strokes, then you'll be in good stead there. Just one last thing to mention: the macula can often be spared due to blood supply from alternative sources. I think the MCA has a branch that covers it as well. So often you can get sparing of the central vision. So because of this, patients might actually not know that they've had a stroke. So the presentation could be quite late, and it might be along the lines of I keep bumping into things because they've not realised that they've lost the left half of their vision and they can't see the door frame or the coffee table, and they've bumped into that. Then just to touch on some of the niche strokes, I've included these for completeness. They sometimes come up, but they might be a bit above the curriculum. The way I tried to understand these was kind of where the infarct is and what that area of the brain is supplying. So Weber's syndrome is a result of occlusion to the paramedian branches of the posterior cerebral artery. And basically what that means is these arteries go on to supply the midbrain. And at the level of the midbrain, you find your third cranial nerve fibers. So as a result of this, you'll get a ipsilateral, so same-sided third cranial nerve palsy. So it gives you the symptoms of the eye pointing down and out, and you might get some ptosis, this drooping of the eyelid. So this is kind of the key point to take away, is that cranial nerve fibers don't cross over. So you get ipsilateral same-sided cranial nerve lesions. So in these strokes, that's why you will have a problem on one side of the face and then the opposite side in the limbs, because the cranial nerve, if the cranial nerve is affected, it's on the same side. If a lower nerve is affected, it crosses over, it's on the other side. Yeah, so in short, the Weber syndrome is cranial nerve palsy, a third cranial nerve palsy on the same side, and then limb weakness on the other side. If you see that combination of features, Weber syndrome, midbrain stroke. So that was the midbrain. Now, if we go down a level, we're at the level of the pons. The anterior inferior cerebellar artery supplies the lateral aspects of the pons. And this gives a pattern of features called lateral pontine syndrome. And the collection of symptoms are again based on the cranial nerve nuclei that are found at the level of the pons. So, firstly, you've got the spinal trigeminal nucleus, and this is basically where the trigeminal nerve originates, which supplies pain and temperature sensation to the face. So you'll get ipsilateral numb face. And then you also have the facial nucleus, so the seventh nerve nucleus as well, and that's responsible for the muscles in the face. So again, you get this drooping face, as well as some tearing of the eyes and some drooling. And then also you get a loss of taste to the anterior 2/3 of the tongue. The cochlear nerve as well is found in the pons, and subsequently you can get a degree of hearing loss. So that's often a key thing to draw out of the question. This is a lateral pontine syndrome, then there'll be a degree of hearing loss. And then finally, the spinothalamic tract runs through this part of the pons, and this is responsible for your pain and temperature sensation to the trunk and to the limbs. So you'll get a contralateral loss of sensation. Then down another level, you reach the medulla, supplied by the pica, posterior inferior cerebellar artery, and this causes your Wallenberg syndrome that you all picked up earlier. And basically, at this level, you've got the inferior cerebellar peduncle, so you get cerebellar signs, ataxia, path pointing, the dysdiadochokinesia. And then you've got your vestibular nucleus, so this is part of the eighth nerve. You get vertigo, so you get spinning, you get nystagmus. There's also some sympathetic fibers, so you get your Horner's syndrome. So that's something to look out for if you see a sort of signs of Horner's syndrome, some cerebellar symptoms, and start thinking Wallenberg's. And then again, spinothalamic tract. So then you get this contralateral loss of sensation. This is kind of the way I learned these sort of three niche strokes, just by working out the different levels and what that would present as. Worked for me. For some other people, maybe just learning the sort of pattern of symptoms also helps. Yeah, I do think it's quite complicated. It's hard to get your head around. So hopefully that helps a bit. And then this is just a slide to highlight some even more niche strokes. So lacunar stroke is an occlusion of penetrating arteries, so supplying the basal ganglia. And there's kind of three types of presentation to look out for. So something that is purely motor, so only motor, purely sensory, or then this ataxic presentation, which is sort of a weird combination of cerebellar and motor symptoms. Then a full pontine stroke, which results in your locked-in syndrome. It's slightly different to the lateral pontine syndrome because there's ischemia to a greater part of the pons. And then the other one to include in here is an ophthalmic artery stroke, which will result in complete loss of vision in one eye. Something just to bear in mind for when you're actually doctors, or if you see someone in A&E or GP, any of these features, facial weakness, arm weakness, speech problems, should just be ringing a bell that this needs to be urgently referred on. So another SBA, what is the single most appropriate initial management here? Okay, cool. A little split here, but the majority going for the correct answer, which is a CT head. So hopefully you get the kind of the key point here is we can't do any stroke management. until we've worked out whether this is a hemorrhagic stroke or not. And to do that, we need a CT scan. So depending on the stroke type, some of the options may have been indicated, but first thing we need to do is to get a CT scan. So on to sort of stroke management. And this is another part of sort of the topic I think you should have a decent idea about. So along the lines of what I was mentioning earlier, what to do if you suspect a stroke. The patient needs an immediate transfer to a facility that can fully assess the patient. And again, at this point, that you can't start antiplatelet treatment until you've ruled out that they're not having a bleed. And then what you can do in the meantime is your Dr. ABCD assessment. So these are your initial steps as kind of recommended by NICE. So when you suspect a stroke, first step is imaging, which would be a CT head to look for any signs of bleeding. They've put in a few points about oxygen and glucose. Basically, you only give oxygen if the SATs are below 95%, and you want to try and maintain your glucose levels, so you don't want them hypo or hyperglycemic. What I've put here are 2 CT scans that you might see in somebody with an ischemic stroke. So on the left, I've put is basically it's a largely normal CT. There are some mild degenerative changes, but that's kind of to be expected in an 80-year-old. And then on the right is a CT scan that shows some old areas of ischemia, these kind of darkened patches at the bottom of the image. And then just another little note on these CT scans is there's a couple of areas of bright white. And these are just areas of calcification that, again, occurs with natural aging. In the coronal plexus, the bit that produces your CSF can become calcified, and that shows up as a bright white. But then these are CT scans that you're really looking out for. So these are your acute hemorrhagic strokes. And hopefully what you can all see is these clearly demarcated white areas. These are the areas that the blood's actually leaking into. Okay, so now you diagnose your patient as having an ischemic stroke. They've got all the clinical features and there's no hemorrhage. Then you've got 3 options basically that I think you need to be aware of and that a stroke physician might implement. So you've got thrombolysis, antiplatelet therapy, and then thrombectomy. So thrombolysis is the administration of alteplase, but only if the patient meets certain criteria. So that's if the patient is currently under 4.5 hours from the onset of their symptoms, and you've excluded a hemorrhage, but it's that crucially if they're under 4.5 hours, that's the time frame you're looking out for. Antiplatelet therapy is your classical treatment, and I think this is a dose that's good to know. You give 300 milligrams of aspirin basically as soon as possible. Then once you've ruled out your bleed, and it has to be within 24 hours. Then this is a relatively new treatment. It was only put into the guidelines sort of 2 years ago. If the patient is under 6 hours from the onset of their symptoms, and then there's a few more criteria in terms of having a confirmed proximal anterior circulation stroke, then the neurosurgeon can go in and physically remove the clot with a catheter. It's very effective. It's basically PCI for a stroke. So the similar system you would do in a heart attack. The issue that this isn't wider offered is because there aren't many centres able to offer it, but I think that will change going forwards. Then just to highlight the chart, there are some other branches that just I don't think are worth knowing at this point. There's therapeutic hypothermia, not routinely used. Complex presentations, things like an ischemic stroke with a new onset of atrial fibrillation. Blood pressure control, again, is only really if there's a hypertensive emergency. The 3 things I've put, I think, are the key here. Just for a bit of completeness, I've included the management for hemorrhagic stroke. This decision is likely to be much more of a senior one. The problem is that they're going to need probably some level of decompression management. The skull's essentially a closed box, and now you're trying to force more into this box. The brain's going to get compressed as a result, and that can have catastrophic consequences. So basically, your treatment here is going to be to alert your senior and refer on. And they're going to get some neurosurgical input. Then the final aspect of stroke management is your secondary prevention. So we've diagnosed, investigated, and then treated the stroke. Now we want to prevent it from happening again. So I've just underlined the key aspects here, but Lifestyle changes, they're going to form the basis of your management. So this is encouraging activity, stopping smoking, having a good diet, reducing the level of alcohol. They're your main areas that you'd consider. The classic long-term therapy is 75 milligrams of clopidogrel, and then also a high-intensity statin. For whatever reason, if clopidogrel is contraindicated, so severe renal disease or an allergy, you can use modified release dipyrimidol and aspirin together. I think some of these doses are just good to be aware of. Even if it's just sort of learning them the night before the exam, it's probably a good idea just to be a bit aware of these doses. And then this is just a summary slide for strokes. And I've tried to condense the information to the most salient points, basically. So just to clarify this box on the right, you give you 300 milligrams of aspirin immediately when you diagnose your ischemic stroke. You maintain that for 2 weeks. And then after those 2 weeks, you move to your secondary prevention routine of your 75 milligrams of clopidogrel. Lastly, in this section, just to touch on TIAs, your transient ischemic attack is sort of your mini stroke, a brief moment of ischemia that can cause a focal neurological deficit, but then crucially, it resolves within 24 hours. So the clot that's caused the obstruction is dislodged. Two scenarios that you should potentially be aware of is that somebody presents to GP or A&E, gives a history, it sounds a bit like a TIA. If it's within the last week, then so if it's within the last week, then you give them the aspirin and you send them within 24 hours to a specialist stroke doctor. If it sounds like these symptoms were over a week ago, then you want to get them seen as soon as possible, but ideally within 7 days. And you might want to do some assessment for an arrhythmia or something like that. And then this is just a summary of TIA management. I've included this ABCD2 score. It's not really used anymore, but I like it as a nice way of sort of detecting the likelihood that a patient's having a stroke. And a score of 4 to 7 is a moderate to high risk of stroke and needs a specialist review. Right, moving on from strokes, here's an SBA.
We've got some feedback in the chat to say these guys like the pace, by the way.
Okay, that's good. That's good to know. Thanks, Bob. Okay. Yeah, very nice. So I thought this question might be a little bit vague, but basically the point I was trying to make is whether you can differentiate idiopathic Parkinson's from other causes of Parkinsonism, and then what you would do about it. So this patient has your classical features of Parkinson's, so tremor, bradykinesia, rigidity, shuffling gait. But crucially, these symptoms are seen on both sides. So the tremor is seen bilaterally, which actually points away from your idiopathic Parkinson's disease, which typically has a unilateral tremor. And then because of this, both your levodopa and your dopamine agonists can be ruled out, as these are Parkinson's disease treatments. There's no point referring to HASUs as not a stroke. And then propranolol is first-line medical management for your essential tremor, which is a good differential, but given the plethora of Parkinson's symptoms, this is unlikely. So the correct answer is your medications review, as the majority of you said. It's likely to be a drug-induced Parkinsonism, long-term treatment for schizophrenia with antipsychotics that have an antidopaminergic action. And then in addition to this, the treatment for chemotherapy induced nausea could be metoclopramide, so another antidopaminergic medication So then the combination of these medications could result in a drug-induced Parkinson's. And for that, we might consider stopping or changing the medication regime. So a bit on Parkinson's. Just a quick review. It comes about due to a loss of dopamine in the basal ganglia, specifically the substantia nigra and the pars compacta. Few causes, so idiopathic, medication-induced, vascular. In vascular, you've got mini infarcts, which kill off the dopamine-producing neurons. Infection can cause it, and then trauma as well. So that was the case with Muhammad Ali. Repeated blows to the head caused a trauma-induced Parkinsonism. And then, so the purpose of the dopamine pathway is to bring about movement. So if this is blocked, then there are low levels of movement, hence the hypokinetic, bradykinetic features. And then this is your pathognomonic triad. Your resting tremor, which is typically described as pill rolling, sort of rolling a small ball between your thumb and your two fingers. Slow movements, bradykinesia, and then stiff movements or rigidity. The cogwheel rigidity phenomenon you see in Parkinson's is where you kind of try to flex the limb of the patient, and it sort of catches at certain points, creating this kind of ticking motion, like you might see in a clock or sort of notches on a cog. Then these are your key medications, and I think it's the side effects that are the key aspects here to know, as it's unlikely you'll be prescribing these as junior doctors. Levodopa is the crucial one not to miss off any drug chart. If it's not prescribed, you can get a neuroleptic malignant syndrome, which is characterized by high temperature, rigid muscles, confusion, changes to blood pressure. And this can result in like a hyperkalemia, arrhythmias, and seizures. So it's quite a dangerous state to be in. The same phenomenon happens with antipsychotics, but the dopamine can be cut off suddenly, and that can cause the reaction, can be life-threatening. Other side effects to be aware of are in your dopamine receptor agonists. These can bring about quite a profound behavior change. So particularly in the form of impulse disorders, where somebody might become a gambler or sexually impulsive or something like that. MAO-B inhibitors have this cheese reaction where you can get too high levels of tyramine. So these are just good things to have in mind for SPAs and just general life. And then this is another area that frequently pops up in SPAs. So a patient presenting with features of Parkinsonism, but then also they have extra features. And so these are your Parkinson's plus syndrome. So just quickly go through multi-systems atrophy. The key extra feature you get is autonomic dysfunction. So things like sudden drops in blood pressure. Progressive supranuclear palsy, so PSP, causes an impaired vertical gaze, so it makes it hard to look down. So this might present with falls. Lewy body dementia, this is Parkinsonism with a cognitive impairment that appear roughly at the same time, and you also get often these visual hallucinations. And then the last one's corticobasilar degeneration, where you get this thing called an alien limb phenomenon, basically where they see their own limb, but they think that it belongs to somebody else's. So it can be quite a distressing condition. And then this is just a summary slide, just to touch on a point on the right-hand side. Basically, the first-line medication for patients if their symptoms are really affecting their quality of life will be levodopa, because it's the most effective. But the issue is that it loses its effect over time, so you want to save it until it's most necessary. And because of that, dopamine agonists are the first line treatment if the symptoms they're experiencing aren't completely affecting their quality of life yet. So that's just something to bear in mind. And then also Parkinson's requires specialist input and diagnosis, basically. So if you see or suspect a patient with Parkinson's disease, then they'll need an urgent referral to neurology to get an appointment within the next 2 weeks to be diagnosed and started on treatment. Functional neuroimaging can be used to differentiate between the idiopathic Parkinson's and then alternative diagnosis. And what will happen in this sort of functional imaging is you'll see a decreased uptake of dopamine. So they'll put a tag on the dopamine receptors, and you'll see this decreased uptake on the scans. So another SBA, what's the most likely diagnosis here? Okay, so a bit of a mix here. So I'll go through this one. So the correct answer is D, is a subdural hemorrhage. I do think this is quite a difficult question. The key being, can you recognise risk factors for bleeding and for falls? So what's most likely happened here is you've got your little old lady who has been trying to move around her flat and then has fallen over because she's got this new hip and this Zimmer frame, and she's hit her head, which has caused a small bleed. Because she's got atrial fibrillation, she's on anticoagulation, and for that, this small bleed in her brain has not clotted and stopped. It's kept bleeding, and what's happened is it's caused a chronic subdural hematoma, and that's causing all these symptoms. The history of 3 weeks of cognitive change is a bit too short for Alzheimer's, and then there's no signs of Parkinson's or hallucinations for this to be Lewy body. And then your normal pressure hydrocephalus presents with this kind of triad of weird, wet, and wobbly. It would be a decent differential, but there are no signs of incontinence here, and the risk factors again are pointing more towards a subdural. It is possible that this could be a vascular dementia, but the fact that she's on the anticoagulation for her AF would point against that. So I've just thrown this in here as a bit of a quick fire way to differentiate between the dementias. These are essentially your buzzwords for each condition. So Alzheimer's, this is the most common, and you get a global cognitive impairment. In a vascular dementia, you'll have this history of clear steps, stable and then a sudden drop, and then stable and then another drop, as these sort of multiple vascular events happen over time. They'll also likely have a lot of vascular risk factors. So there'll be a smoker, they'll have diabetes, they'll have had heart problems in the past. Frontotemporal dementia will be a younger individual, usually under 65, and they'll have a behavior change, quite a profound behavior change. As sort of touched on earlier, Lewy body, you're going to get Parkinson's symptoms and some visual hallucinations as well as your cognitive impairment. Then normal pressure hydrocephalus is another exam question favourite. As you get this triad of weird, wet, wobbly. So the cognitive changes, there'll be signs of incontinence, and then they'll have some degree of ataxia or poor balance. And important to note, it's a reversible cause if you sort out the hydrocephalus. I wouldn't worry too much about dementias. I covered them in a care of the elderly talk for the 5th year. So if it's something you'd like to go through, then that's on the SPLICE YouTube. A bit of a shameless plug there. So let's do another SBA. Okay, yeah, very nice. So the majority of people getting this one correct. So this is assessing your ability to differentiate between different types of headache. So the reason that this is a migraine is it covers your main diagnostic criteria. So multiple episodes, typically severe and typically described as throbbing. We'll go through some of the other answers and the other causes of headache in a minute, but let's do another SPA. Lovely stuff. So this is a classic sort of two-step question where you've got to work out the diagnosis, and then once you've worked that out, you need to work out the treatment and which intervention is going to help the most. So this patient, as I'm sure the majority of you have worked out, is suffering cluster headaches. So the short history is to try and make it a bit trickier, but this might be the first kind of cluster of headaches that this patient's ever experienced, and may go on to experience more in the future. And the features suggesting of this are that the headaches occurring at the same time over the last few days and only lasting an hour. So cluster headaches have a rapid onset and apparently are incredibly painful. So a good differential for a suspected subarachnoid. But the eye signs and the repetitive nature points more towards your cluster headache rather than a subarachnoid hemorrhage. And as you've all said, the correct answer is oxygen, which has been shown to reduce pain if taken during an acute attack. It's an okay option in A&E, but actually the most effective treatment apparently is subcutaneous sumatriptan. So that's another thing to bear in mind. Verapamil can be used for longer term prophylaxis. Amitriptyline used in trigeminal neuralgia. Prednisolone used in giant cell arteritis. So just some of the other things there. So headaches. This is such a common presentation, one of the most common presentations just in the whole of medicine. So this is a similar table to I showed at the start, and it's one way to differentiate between the causes of headache and the likely etiology. So again, your sudden onset, more likely to be your vascular causes, so your TIAs, your strokes, your subarachnoids. Acute causes developing over minutes to hours, more likely to be infective, meningitis, encephalitis. Longer term, over sort of weeks, months, might be an intracranial mass or a tumour. And then your headaches that are persistent, keep coming back, are things like migraine, cluster headache, or your trigeminal neuralgia. So just to quickly run through a few of these. Tension headache, it's really, really common, described as this bilateral tightness, like a band going around your head. Many proposed causes: referred pain from the scalp, neurovascular irritation, muscular cause from the neck. Crucially, there's going to be no nausea or vomiting, and then some light pain relief is likely to be all the management you'll need. Then migraine, another very, very common presentation. The key features to remember for migraine: you get attacks every few weeks or months. Each attack lasts longer than 4 hours. It's usually unilateral and will be described as throbbing. You can often get an aura or this sensation beforehand. So this might be a smell or a visual disturbance before the onset. And then in terms of your management, avoiding the triggers. And then your first line management for an acute attack is a triptan. Then your prevention, usually with topiramate, but good to be aware that topiramate is teratogenic. So propranolol will be used in women of childbearing age. And then cluster headaches, which we've touched on already, which is fortunately quite rare, but you get this cluster of really painful headaches, 1 to 2 severe headaches a day for a few days, and they go away and they come back. Yeah, like we touched on, oxygen can be given in acute attacks, and then verapamil, your calcium channel blocker, can be used in prophylaxis. Then just two other causes of headaches to be aware of. Trigeminal neuralgia, which causes this sort of electric shock, like pain in the face, which can be, again, extremely annoying and really affect people's quality of life. And this is treated so successfully with carbamazepine that it's pretty much diagnosed. If you give somebody carbamazepine, it goes away. Then temporal arteritis, or your giant cell arteritis, which, if you remember from rheumatology, this can cause a sort of headache. Things like pain on combing their hair or brushing their face. And this can cause loss of vision if it's not treated and picked up. So your acute management is your high-dose steroids. Right, so just quickly, a bit of interaction. If you put into the chat what you think this spot diagnosis is for a CT head, I'll get a few coming through, and then I'll go through each of these. Yeah, so subarachnoid coming in, excellent, that's correct. So this is your subarachnoid hemorrhage. Then this next one. Excellent. So this is a good image of an extradural. This one. Yeah, good. So this is a subdural. Is this acute or is this a chronic subdural? Yeah, excellent. So this one's chronic. So then what's this likely to be? Yeah, so this is more of your acute. So just to kind of go through this, these are the layers of the skull. So this is kind of going through, and you've got your 3 meningeal layers. So the first, as you said, was subarachnoid, extradural, and then your acute and your chronic, and then acute subdurals. So the first area that a bleed can occur is between the skull and then the dura mater, so the outer layer of the meninges. And as the name suggests, this is extradural, outside the dura. Then your dura mater are connected to the skull along the suture lines. So a collection of blood will form in this sort of confined space, this pocket, which gives it this dome shape that you get on imaging. And it primarily occurs due to trauma in the temporal region, where you've got this middle meningeal artery lying very close to a thin bit of skull, and it can bleed rapidly. It can spread quickly and compress the brain, causing quite a lot of damage. And these patients need an urgent referral to neurosurgery for decompression. Then the next space is between the dura and the arachnoid mater. So this is your subdural bleed, so underneath the dura. And here there are no adhesions, so the blood can fill all the way along the side of the brain, giving it this kind of crescent shape. So the damage here are these fragile veins that bridge across the meninges. So in an acute setting with quite an extensive bleed, blood can fill up in this space quickly, which can compress and shift the brain across the midline. However, often because it's a vein that's bleeding, and if it's only a small vein, the bleeding can be slow and it can build up over a few weeks. So for this reason, you should be quite concerned about your patients who are on anticoagulation and have had a head injury. So one of the CT guidelines is that anybody with anticoagulation and has banged their head should get a CT head. Just another point to note on the acute versus chronic subdural. The reason that you get like a bright white picture on an acute bleed is due to the level of hemoglobin in acute blood. So you've got lots of hemoglobin in blood normally, and the iron in that shows up on a CT scan as being white. But as that blood sits there for a little while, the hemoglobin's broken down, the iron is removed, and then the blood kind of goes to this darker color. It's the same as the CSF in the ventricles, so it's just a fluid there. So that's how you can tell. So if it's acute on chronic, you will see this split level of bright white of the acute blood and then dark of the chronic blood that's been sitting there for a while. And then thirdly, you've got this space that's in between the arachnoid and the pia mater, which the pia mater just covers the layer of the brain. And this is where you get your subarachnoid hemorrhages. So this is your thunderclap being hit on the back of the head with a baseball bat headache, very severe, sudden onset. Often we'll have signs of meningism as well, as the blood irritates the meninges, often caused by ruptured berry-aneurysms. And berry-aneurysms can just occur. They can be idiopathic, but then there are a few conditions that predispose you to them. So polycystic kidney disease, and then connective tissue disorders such as Ehlers-Danlos or Marfan's are good things to be aware of. And then these patients need a CT head and a referral to neurosurgery. The other thing that also to be aware of, you can give nimodipine to these patients, which is a calcium channel blocker, and basically blood can irritate the outside of other blood vessels, and they can go into spasm, they can shut off, and that could actually lead to an ischemic stroke on top of a subarachnoid. So giving them this calcium channel blocker can allow the blood vessels just to relax and prevent that spasm. So just something to be aware of. Right, another SBA. Okay, nice. So there's a bit of a split here, but the majority getting the correct answer. And that's syncope. And this is quite a classic style question where they kind of try and throw you off a little bit by trying to draw you down one path. So there are a few features in this vignette that actually point to syncope over a seizure. So firstly, there's this prodrome of feeling lightheaded, which kind of points towards a faint. More than a seizure, but the key differentiating feature is in the recovery time. So after a seizure, you will get a significant period of post-ictal, post-seizure drowsiness and confusion, and it will take quite a while, hours really, even days before they start to feel better. Whereas in this scenario, she recovers quickly and is feeling better after she had some water. In syncope, you can get these convulsions, or they can shake a bit, and things like incontinence as well. It's a bit of a red herring, but she's been at a party, she's had a lot to drink. It's possibly understandable that's happened. Drop attack, pseudoseizure are differentials, but a lot less likely than just generalized syncope. So another SBA, and then we'll go through a bit of epilepsy. Okay. Excellent. So again, a bit of a split, but the majority getting this one correct. So this is testing whether you can recognise the different types of epilepsy. So I think this is a tough question. It's the answer here is temporal lobe epilepsy, and the features to pick out here are these automatisms. So your lip smacking, chewing, other things like the somatosensory aura, feeling of deja vu. And then the confusion and amnesia following these events. So the other popular answer was absent seizures. So absent seizures, you won't get these automatisms, and then also they often tend to have a bit of a quicker recovery time. And then a couple of the other answers. So parietal lobe epilepsy presents slightly differently. You will get more sort of paresthesia, like a sensory issue. And the alcohol isn't a history, isn't significant there. And then narcolepsy is your daytime sleepiness and just falling asleep inappropriately, and that doesn't really fit with the clinical picture. So epilepsy, it's a fairly specialised area of neurology, but it's good to be able to recognise it and understand a bit about what's happening. Some quick definitions is it's important to differentiate between seizures and epilepsy. So a seizure is a spontaneous, uncontrolled period of abnormal brain activity, and there are many different causes of a seizure. Whereas epilepsy is a syndrome whereby sufferers are going to have a continuing liability to have seizures, and you need a minimum of 2 seizures to diagnose epilepsy. And then some differentials of epilepsy and seizures are here. So syncope, as we touched on, will have a quick recovery time, and they might have been feeling lightheaded, this kind of prodrome beforehand. Migraine can present a little bit like epilepsy or a little bit like a seizure, but they'll get an aura type problem, and they'll have had this all their life. There might be some risk factors. TIA, so a transient ischemic attack can cause similar features, but again, there might be some vascular risk factors and things like slurring of speech and some weakness of the limbs. You can get something called a non-epileptic seizure, and this is more remit of psychiatry, but comes with things like mental health, personality disorders. It's not faking a seizure per se, but it's not necessarily as well understood as epilepsy. And then space-occupying lesions can cause seizures in themselves, so tumours may present with a seizure. Then there are different types of seizure you can have. There's a classification divides them into generalized and focal seizures. So generalized involves neuronal networks on both sides of the brain, and often results in a loss of consciousness. Tonic-clonic seizures that you tend to imagine are the ones you kind of tend to imagine when you think of a seizure, where there's this brief tonic phase where there's extension of the limbs and the neck, followed by a loss of consciousness. And then you get this clonic phase of convulsing limbs up and down in a jerky motion, and you might get some features like incontinence, tongue biting. And this is going to be followed by quite a long period of post-seizure confusion, headache, drowsiness. Another common generalized seizure is your absent seizure. So this usually happens in childhood, and is basically characterized by a child sort of stop what they're doing and they just stare into space. They might go pale, they don't seem to respond to the outside world. And then suddenly they come round again, and after the attack they regain consciousness and function pretty quickly. And then some other types to be aware of are myoclonic or clonic only seizures, and then also you can get tonic or atonic seizures as well. Atonic seizures being you just lose all tone and just drop to the floor. Tonic seizures where you just become very, very rigid. Then you can get focal seizures. So this was what the second question there was on, and they're called such as they are a consequence of abnormal neuronal activity in a specific part of the brain, a focal part of the brain. They can be classified as simple, where you have consciousness and awareness is maintained, or they can be complex, where then there's a lot of consciousness and awareness. And these can be a focal motor seizure where a single muscle or muscle group is affected. They can be focal sensory with numbness, visual or auditory hallucinations. And then also good to know about a secondary generalized seizure, which is a seizure that has started focally and then seemingly spreads to result in a full-blown tonic-clonic seizure. And then also something to note is that focal seizures can be attributable to specific lobes of the brain. So, like the SBA, the temporal lobe is more common for hallucinations, automatisms, deja vu. If there's a frontal lobe seizure, we might have motor signs, commonly the head or neck, and then they might have this feature called a Jacksonian march, where the symptoms appear to sort of march up the limb. So starting at a distal point and moving towards the face. So it might start in the hands, move up the arm, into the shoulder, then into the face. That would be a Jacksonian march. And then, yeah, so your parietal lobe, you get this sort of paresthesia, changes in sensation, and occipital can cause some flashes and changes in vision. And then a little bit of information on the management of, or the immediate management of a seizure. It's always good to note the time a seizure started, as this can help guide your management. Things you can advise parents is to sort of clear the area, remove any dangerous objects, put a pillow or something soft under their head to protect it. And then once the seizure is stopped, make sure that the airway is open and you can put them in the recovery position. And then discussed a little bit in the acute lecture, but you can try and terminate these seizures with a benzodiazepine. The first line in the community setting is this buccal midazolam that you can rub onto the gums. But if you've got IV access, you can use lorazepam as well. And then patients presenting with seizures are going to need a specialist review for diagnosis further down the line. Just a small slide on the investigations used in epilepsy. EEGs largely used once epilepsy has been confirmed as the most likely cause of the seizure, and they can determine the seizure type and the location of onset. Neuroimaging might be used in the acute or the diagnostic setting, and can be important to rule out things like a space-occupying lesion. It will be performed in any child under 2, because that's the most likely cause, would be a tumour there. And then some other tests, you might perform a blood test looking for metabolic abnormalities, high or low blood glucose, electrolyte, calcium abnormalities, things like that. And ECG as well, because it's possible that an arrhythmia has caused like a hypoxic seizure. Okay, another SBA. We're nearly finished. Well done for sticking with this. Okay, so there's the most common answer here was A for valproate. So the correct answer is B, carbamazepine. There's potentially more scope for 5th year because this is including contraception. But I wanted to make the point here about these P450 inducers and inhibitors, because this is something that comes up quite a lot. And the epilepsy drugs and the TB drugs are kind of the 2 big classes that seem to affect your cytochrome P450. And it's quite a good idea just to have in your head before the exam. And basically, the reason that this is carbamazepine over valproate is that the carbamazepine is an inducer, so would therefore break down, cause this enzyme to break down the pill at a greater rate. And if you've not got the right level of contraception, that will increase the risk of pregnancy. So just quickly, this is the first line medications for different types of seizure. These are all really highly specialized medications. Will be started and changed by the specialized epilepsy doctors. And I think it's useful to have a rough idea, but actually I think this is perhaps a bit more what's useful for you guys in terms of to know is the side effects again of the more common anti-epileptic drugs. So there are a few aspects to be aware of when advising patients in GP A&E for prescribing another medication. So valproate is a good drug, but it's teratogenic. It's not used in women of childbearing age. It can be it's quite a dirty drug. It has a lot of side effects and interactions. Carbamazepine has a few side effects to be aware of. One of those being Stevens-Johnson syndrome, which is it's a dermatological condition that affects the skin breakdown. It can also cause the agranulocytosis, so it can cause a complete wipeout of your immune system. Just on that point, the other drugs to be aware of are the C's, so carbamazepine, then the drug for hypothyroidism, so carbimazole, and then the antipsychotic, you've got clozapine as well. So if you see those three, they can be cause of bone marrow failure, basically. And then, as I mentioned in the SPA, so your anti-epileptics are common interactors with the P450 enzyme, which is involved in the breakdown of medications. So any drug that will induce cytochrome P450 is going to break down that medication a lot more quickly. So like I touched on with the pill, the reason that's significant is because if you're breaking down your contraception much quicker, then you don't have any contraceptive cover. The opposite effect is if it inhibits that enzyme doesn't break it down, you can get a massive buildup in that medication, in another medication that's not being broken down. So a good example for that is warfarin. So if the P450 is inhibited and it's not breaking down your warfarin, you can get a massive buildup and your INR can go through the roof. And this kind of thing at the bottom is a bit of a rule of thumb that I made up last year or in fourth year when I was revising these. But basically, all the anti-epileptics are P450 inducers, except for sodium valproate, which is the inhibitor. Then the opposite is true for TB drugs, which are pretty much all inhibitors, except for rifampicin, which is an inducer. So all you need to do is basically, if you see an epilepsy drug and it's not valproate, it's likely to be an inducer. If you see a TB drug, it's likely to be an inhibitor unless it's rifampicin. So it's not the simplest thing to get your head around, but it means you don't have to remember long lists. You only have to remember two medications, which are the opposite way around. And there's a mnemonic for the inducers, which is, it's like crap GPs. And so the way I remembered that was crap GPs induce pain. So they're inducers, and there's an R in crap GPs. So that's the rifampicin, and that's kind of how I remember it. Again, it's just something maybe to look over the night before the exam. It's not something to get too worked up over. Right, another SPA. Okay, nice. So I apologise. I've got my traffic lights messed up here. This shouldn't be an easy question. This is quite a tough one, I think. And so the question's asking what's the most likely diagnosis, and there's quite a lot going on in this SPA. So I've tried to break up some of the neuroscience here. So he's an older patient who presents with an asymmetrical feature of a right foot drop. This sounds like it's spread over a decent amount of time, and it's up to the thighs. A slight red herring in that he's had some gastroenteritis treated with metronidazole, so could indicate Guillain-Barré syndrome, as Campylobacter could have caused it, or metronidazole neuropathy. But the time course is a bit too long for either of these to take place. Then we've got some of these upper motor neuron signs. So you've got spasticity, hyperreflexia, a positive Babinski sign. But then also mixed in, you've got some lower motor neuron signs, so atrophy, fasciculations. When we put all those together and you compare the answers, the diagnosis that fits best is, like the majority of you said, is your ALS, amyotrophic lateral sclerosis, which is the most common form of motor neuron disease. So that's excellent work, well done. The other two options there, so Charcot-Marie-Tooth, also called hereditary motor and sensory neuropathy, which is a lower motor neuron only, and also there's no sensory features, so points against that. And then subacute combined degeneration of the cord has this classical triad, and also may be associated with some nutritional deficits, so B12 usually. So just a couple of slides on a few conditions. So do multiple sclerosis first. It's a good condition to know a bit about. It's basically a chronic autoimmune disorder with damage that causes demyelination of the neurons in the central nervous system. It often presents in younger patients, particularly younger women. An MRI is very useful as a modality to detect any lesions. And then there's this classic phrase of two areas of damage separated by time and space. So you need two MRIs showing damage that's at different times and in two different locations. And then in terms of management, it's come a long way recently, but again, it's very specialist management that will be done by the neurology team. So steroids can be helpful in acute attacks, and then also some symptom relief. So baclofen or tizanidine are used for muscle spasticity. Pain medication as well, so working up your WHO pain ladder. And then mental health support is another thing to think about if you're talking in terms of management plans, because it can often be quite a tough condition to come to terms with. Then, as we touched on in the question, motor neuron disease, another very specialist diagnosis, but good to know a little bit about. So as the name suggests, it only affects motor neurons, so can present with upper and lower or mixed motor neuron signs. It's most common in older men, and then there are some different types that could know a little bit about. So ALS is the most common, and that typically presents with lower motor neuron signs in the arms and then upper motor neuron signs in the legs. That's typically the presentation. Bulbar palsy has the worst prognosis, and that can affect the muscles of the pharynx, the larynx, the palate, and then the tongue as well. And the problems arise there is that they can't control their own airways, and so they get aspiration pneumonias, and that's often the cause of death. It's a clinical diagnosis, so EMG can be used that might show some denervation, and then management is it's got quite a poor prognosis. These patients might need ventilatory or feeding support. There is a medication, Riluzole, can be used to help slow the progression, but it won't cure the disease. But it's quite an interesting condition to write questions on, because there's a lot of different features going on. The key one to remember is it's just motor symptoms only. Then just to touch on a few slides on polyneuropathies. So these are disorders of peripheral or cranial nerves with symmetrical widespread distribution that can affect multiple nerves. And you can get a sensory or a motor neuropathy. So your sensory neuropathies are the classic glove and stocking presentation in diabetic neuropathy, where there's numbness and loss of sensation over kind of the areas, your hands and your feet, where you'd wear your socks and gloves. Then motor neuropathies present with a kind of a lower motor neuron sign, so distal wasting, weakness, a loss of tendon reflexes. You can get clumsiness, like dropping cups of tea, or a high stepping gait if you've got a bilateral foot drop. here is a nice list of causes. I've split them up a little bit like a surgical sieve, and it's just potentially a list to flick through at some point and go through and just be aware of. Really, you don't need to learn too much depth. And then what we're going to do to finish is just go through a few sort of revision questions that might be good to know a bit about. So get a poll up for this one. Thank you. Yeah, very nice. So this is just a question to test your knowledge of some of the cranial nerves supplying the eyes. And yeah, so your sixth cranial nerve, your abducens nerve, is the nerve that abducts the eye. That's your lateral rectus muscle. And as you've all correctly said, this is on the right side, and cranial nerves are ipsilateral presentation. Good. So another SPA quickly. Yeah, excellent. So I thought this was a little bit of a tougher cranial nerve question, but again, the majority getting this right, which is excellent. So this is testing whether you know the different functions of the cranial nerves. And so specifically, cranial nerve 5, trigeminal, it has some sensory function, but it also has motor, and those are the muscles of mastication. The top three there would be features of a facial nerve palsy, and then posterior third of the tongue in terms of taste is the glossopharyngeal nerve. Excellent. So this is kind of just another. I've got 2 revision slides. So this is cranial nerves 1 to 6, just explaining their function and then some problems that you might have. Then cranial nerves 7 to 12, again the same sort of thing. This would be useful for if you are going through your OSCE sort of preparation. You need to do a cranial nerves exam. These are the kind of things you might be looking for or might see pathologies of when going through. Then I think this is the last SPA. There might be another one. This is just whether you can calculate a GCS score. Another thing I think is quite useful to go through. Okay, bit of a mix here. The correct answer is D, is 10. So just a point on GCS. It's just a good thing to know, and to roughly be able to work out. I think there was a question in our finals actually that just required you to work out the GCS. But your total score is out of 15. Your minimum score is 3 because there are 3 areas assessed, and the minimum score for each area is 1. So you've got movement, which is a score out of 6, verbal is a score out of 5, and then eyes a score out of 4. So speech confused, but he is forming real words. So this would go down as a confused speech. So you get 4 out of 5 for verbal. He moves his hand to push away the painful stimulus. So this would be a localizing to pain. So you can get a 5 out of 6 for that. But then, and eyes is I've written here, is essentially your ABBU. So he's not responding. He doesn't open his eyes to pain, so he gets a score of 1. And when you add those up, that gives you your score of 10. So this is just a little table that goes through and gives you the 3 categories and the features there. I think it's just quite a good thing to know. So eyes, like I say, is ABBU. So 4 if they're alert, 3 if they're responding to voice, 2 if they're responding to pain, and 1 if they're essentially unresponsive. In terms of the motor response, I like to think of it in pairs. So 6 if they're completely obeying commands and moving, 1 if there's just no response to anything. That's your kind of 2 different ends of the spectrum. And then localizing to pain, I like to think is sort of flexing towards the pain. So if you squeeze something, they move towards it. Withdrawing is extending away. So they're trying to get away from the pain. And then the flexor response to pain, extensor response to pain are these kind of these very low function things. So they flex all their limbs up in the flexor response to pain, and the extensor response to pain is they extend everything out. It can often be a bit difficult to differentiate between the 2, but localizing to pain, somebody will squeeze their trapezius and they'll try and move the hand away. Withdrawing to pain, they'll just try and drag their shoulder out of the way. Whereas the flexor response, extensor response are a bit more, they're unresponsive, but all of the limbs move. And then the verbal one is the bit I used to find most difficult, but you can kind of learn just the different steps there. Final slide, just some buzzwords for a few other conditions. So raised intracranial pressure is a good thing to be aware of. And there's Cushing's triad for that. So if you see hypertension, so high blood pressure, bradycardia, low pulse rate, and then irregular breathing, have a think, is this person got raised intracranial pressure? If there's a patient who tires later on in the day, or tires on repetitive movement, think about myasthenia. Foot drop, the most common, the most important thing to be aware of there is that's the injury of the common peroneal nerve. There's this condition, neuralgia paresthetica, which is caused due to compression of the lateral cutaneous nerve of the thigh. That often comes up in a question. Wrist drop, radial nerve, small muscles of the hand on the nerve. So just things to think about. But thank you for bearing with me. That was just about an hour and a half. So well done for sticking through that. If Bol or Shret, one of you could bang the feedback in the chat, I'd really appreciate it if you could just fill that out. And we can try and help see if we can tailor these lectures to something that's more useful. But thank you all for sticking with it. And if I don't see you all again, good luck for your exams. Thank you for joining. And yeah. If you've got any questions or anything, feel free to send me an email or drop me a message. I'm very happy to answer and try and help out.